Well,
Thank
thank
you all.
you all for joining. This is part of a NORC Inspire new type of initiative that is being led by one of the NORCs. And in that, we are inviting speakers from different NORCs to come virtually to other NORCs to present. And so trying to create more collaboration, cross-fertilization of ideas, and hopefully new research grants will emerge. So it's my pleasure to introduce to you Dr. Jingyi Qian. She is Assistant Professor of Medicine at Harvard School of Medicine in the Division of Circadian and Sleep Disorders. So they actually have a whole division of circadian rhythm and sleep disorders. She is currently funded on a K99 ROO from NHLBI on the timing of physical activity on cardiometabolic health outcomes. But today she's going to be presenting some findings from her ADA fellowship grant. And she will talk about the interplay between meal timing, melatonin, and MTNR1B, diabetes risk variant on metabolism. So I'm going to turn it over, and Jingyi tells me she wants to be very informal. So if there's questions as she goes through her presentation, please raise your hand on Zoom. Please keep your cameras on. It's always better to have speakers speak to actual human faces rather than cartoons or names that are written. And then we'll have some time at the end for questions and discussion as well. Take it away, Jingyi.
Thank you. Thank you for the nice introduction. And thanks for this opportunity to present our very, exciting work here. Yeah, and just in case, because when I share the screen, I may not be able to see people raising their hands very clearly. So just feel free, you can just unmute yourself and shout out. Okay, now let me share my screen. Yeah. So today I will be talking about the interplay of meal timing, melatonin, and then MTNR1B type 2 diabetes risk variants on glucose metabolism. So here is a general outline. So I'm glad we actually have a lot of endocrinology here today, but just bear with me. I'm still going to go through a very brief introduction on type 2 diabetes and glucose metabolism. And also, the circadian system, melatonin. And then I'm going to go over a little bit like the overview of the power of studies on how the melatonin signaling affects glucose control. And then we will have facing all the, like we always do, we will facing a lot of paradoxical evidence. And we have a central hypothesis how to kind of explain all the paradoxical evidence. And then last, I'll introduce our newly finished a melatonin placebo double-blinded randomized control trial, crossover control trial, to let you know our new exciting results. And then last, I will go over a little bit about the future research directions. So first, introduction. We know glucose homeostasis is very important to human health. It's not only just because blood glucose is a very important source of energy, but also, either, you have the glucose level, the blood glucose level is out of the optimal range. For example, if I have a low blood glucose level, hypoglycemia also called, you'll have kind of very severe health consequences. People will pass out, coma, or even can be fetal. And also have high blood glucose level is also not good, which is AKA, type 2 diabetes. That's a condition we call it diabetes. When you have chronically hypoglycemia, it will kind of increase your risk of cardiovascular disease, causing nerve damage, kidney failure, blindness, etc. So in a healthy condition, under normal condition, the glucose homeostasis was maintained by a closed feedback loop involving a lot of tissues like pancreatic islet cell, liver, also a lot of peripheral tissues. So here, if you look here, so for example, if you just eating meal or drinking some, sodas, so you will have increased high blood sugar, and this will send a signal to the pancreatic beta cell to secrete insulin. And then the insulin will send a signal to the either liver or the peripheral tissue, tell them to kind of uptake the glucose, and how well those tissue, in response to the prevailing level of insulin, is called insulin sensitivity. Of course, this is a very kind of simplified version of how the glucose regulation. If you have a low blood glucose sugar, low blood sugar level, so the pancreas will secrete a different hormone called a glucagon, and tell the livers to kind of like turn the glycogen, that stored glycogen, into glucose released to the circulation, so to maintain a normal blood sugar level. So this is a very simplified version of how the glucose homeostasis was regulated, or in reality, you know, they require a lot of interplay of many other glucose hormones and peptide, including like glucocortical, epinephrine, and incretin, etc. So in research setting, we kind of using a pretty standard test, like called glucose tolerance test, to assess a person's ability on how quickly their body can clear sugar from their bloodstream. And also this glucose tolerance test, as many of you know, is often used in clinical setting to diagnose diabetes. So here on the left is an example of oral glucose tolerance test, where they usually drink like 75 glucose drinks at time 0. And this is the lean control. So you will see, you know, their glucose level will increase, you know, modestly, and also kind of induce the insulin secretion, where to tell the body, okay, it's your time to clear the glucose level. But however, when people have impaired glucose tolerance, also we call them, they probably have pre-diabetes. You can see that even though their glucose level is roughly similar, you know, not that much elevated as compared to lean control, they actually secrete way more insulin to maintain this glucose level. So indicating they will have like probably like some insulin resistance. But then in type 2 diabetic patient, you will see the glucose level cannot be maintained low. So after glucose challenging, they're gonna reach to hyperglycemia. And in the meantime, you see their pancreatic beta cell actually is dysfunctional. They're unable to secrete enough insulin to compensate for this increased glucose level. So this is a typical oral glucose tolerance test. And also we have a lot of variations of different glucose tolerance tests, such as the intravenous glucose tolerance test, which is you know, like you basically, instead of ingest the glucose, you infuse a glucose through the vein, bypass the GI tract. And this test also have a lot of sophisticated mathematical modeling that was developed to allow you to really teasing apart all the key components, like you know, different phase of beta cell secretion capability, and also insulin sensitivity, or you know, like or you know, insulin glucose uptake independent of insulin, all those index from using this test. And also we have mixed meal test, which is a standardized meal. So it's kind of just like, it's similar to oral glucose test, but it's more in a more realistic setting because it's a meal. So here I'm going to introduce like a very important kind of concept called disposition index, which is also often like an index that you can calculate based on all the glucose tolerance tests. So in a simplified term, so for people, so the disposition index is the index that describes the capability of pancreatic beta cell to secrete additional insulin to compensate over time for alteration in the insulin sensitivity. To simplify it, so for people who have the same degree of glucose tolerance, so the product of insulin secretion and insulin sensitivity will be constant. So forming a approximate hyperbolar curve, and this constant is being defined as disposition index. So for example, here, you know, we have somebody have a very high insulin sensitivity, then they didn't need to secrete that much insulin. So you can see here, they stay on this line. But for somebody who have reduced insulin sensitivity, but if their beta cell can compensate by secreting enough insulin, so they are kind of have the similar degree of glucose tolerance. And for everybody was above this hyperbolar sign, we can consider them healthy. So they have very healthy, you know, glucose tolerance. But if someone is, you know, have reduced insulin sensitivity, but cannot compensate by secreting enough insulin, so they are, you know, kind of fall into this diabetic status. And this index also have been used in a lot of like, I think a lot of epi studies, because it is very powerful predictor for the risk of eventually developing type 2 diabetes. Now talking about type 2 diabetes. So we probably all know that type 2 diabetes is a really growing major public concern. So this is kind of the population across 15 years in United States at different geographical location, and the percentage of people diagnosed with type 2 diabetes, and you can see it's becoming like more and more dark blue as time goes by. So we know diabetes is the 8th leading cause of death in the United States in 2020, and it also kind of have a huge economic burden, which like just total cost of diagnosed diabetes in 2022 is like over $400 billion. Some common risk factors that we know for type 2 diabetes, including like overweight, aging, have family history of diabetes, and also being physically active. So one of the recent identified risk factor is actually circadian and sleep disruption, which has been gaining a lot of attention recently. So now, next, I'm going to move to give you a brief introduction on what is the circadian system and the circadian hormone, melatonin. So circadian system, okay, so nearly all organisms on this earth will evolved to have a circadian system. So this circadian system is help organism to adapt to the 24-hour environment cycle that is generated by the Earth's rotation. It helps to anticipate the change in our environment, such as radiation, temperature, and food availability. It plays an essential role in the survival of all the beings on the Earth. So in mammal, so this circadian system is governed by a hierarchy of multiple circadian oscillators. So starting with supercapacitor nucleus in the hypothalamus. So this is also called, abbreviation as SCN, is called our central circadian clock. So it will kind of receive light information from retinal hypothalamic tract, which sets its timing in the circadian clock, and then it will like through regulating hormones or neural circuits or regulating body temperature to sync all the other like peripheral circadian oscillators in different organs to make sure our body are in sync. So light, because it's directly kind of resetting the SCN or changing the timing in the SCN, is the strongest signal for zygiber or entrainment cue, we call, for the whole circadian system. But recent study also shows that both eating and activity, they actually can, can just independently setting the timing for all the peripheral tissues. That's also causing a lot of interest in study the timing of eating and timing of physical activity, but that's a different topic here. So for one key feature of all the the circadian oscillator is that so under constant condition, for example, here we have the SCN in a petri dish, so a constant condition. You will see this rhythmic cell autonomous kind of like oscillating of this tissue. So here is just the SCN in a petri dish, and this is just, you can see it's oscillating with this kind of transcribed like bioluminescence. And this oscillation was discovered is being governed by an intracellular molecular clock composed of highly conserved transcriptional and translational feedback loops. So this molecular clock is almost nearly in all our cells and tissues. And they also control a lot of functional genes, like we call it clock control genes, functional genes, which tissue-specific functional genes, and will kind of regulate our behavior, our physiology, like including glucose metabolism, energy metabolism, cardiovascular function, nerve system, and immune functions. So here today, we're gonna focus on one aspect of how the circadian timing system regulates our glucose metabolism, which is the melatonin. So melatonin is famously known as the circadian hormone or the night hormone, which is high normally during the night. So it is directly under the control of the SCN, so our central clock here. So in our circulating system, so basically almost all the melatonin level we see in our circulation is secreted by the pineal gland. This is because if you lesion the pineal gland, the melatonin rise will be gone in the human. So this, the melatonin secretion is directly under the regulation of SCN. And if you are in the condition of constant condition, again, that's how you establish what is circadian rhythm. So if you put someone, so here is a example that, we have like, we have a lot, multiple healthy, participants in a constant condition, which is like constant darkness, where their light level is under the below 1 lux. And they will stay in the lab like for probably 3 days. And you can see this very rhythmic, even though different melatonin level, very rhythmic oscillation or in the melatonin level. And the nocturnal, the rise of the melatonin level is considered the circadian evening or circadian nighttime. And if you expose them to light, so you can see this acute inhibition of the melatonin. So this is just kind of regular melatonin, how the melatonin was regulated by the circadian system. So on the other side, we know that, because we can get melatonin supplements, because melatonin is a naturally secreted hormone, so it's considered very safe. You can basically get the melatonin supplement like around the corner, like from the CVS or Walgreens. So it is estimated that like 3 to 20 million Americans are actually taking melatonin right now to treat sleep problem, primarily without prescription or without any medical supervision. So this can cause some problem. So this is because the typical dose of melatonin supplement we get from the pharmacy can range from 3 to 5 milligram, or sometimes even 10 milligram you can find on over the counter, and they can elevate the circulating melatonin level to 20 to 50 times above your physiological level. So it's really, really high. So that's why it is important for us to understand what is the effect of melatonin on our physiology, to know whether we're actually using this supplement, properly. So okay, so next, I'm going to talking about the current evidence or the studies out there, particularly focusing on how the melatonin signaling affects glucose control. So the role of melatonin and the circadian system in glucose control was like gained a lot of attention in the past kind of like 15 or 20 years, is because a GY study, genome-wide association study, finds that SNPs, a single nuclear polymorphism in the MTNR1B, which is a melatonin receptor, is strongly associated with increased fasting glucose level, impaired insulin secretion, and increased risk of type 2 diabetes and gestational diabetes. So here's just some example showing here, the SNPs is highly significant associated with fasting glucose. And here is, because G allele is the risk allele in this SNPs. So you can see that for fasting glucose level at baseline, you almost see a dose response, with homozygous risk allele carrier have a much higher fasting glucose level. And also after 10 years follow-up, they also have more increase in the risk allele carriers. And most importantly, so it was found that this SNP, this variant have one of the strongest effects among any of the over 200 known type 2 diabetes risk variants on lowering the disposition index, which is a kind of a marker for glucose tolerance. As you show here, is also show a dose-dependent reduction in the disposition index. And what makes it more relevant to all the population is this is a very common variant. So, like for people with a European ancestry, like almost half of them will carry at least one copy of this risk allele. And this number is like 66%, like 2/3 of the East Asians, 40% of Hispanic, and 13% of African Americans. So it's very common, affect lots of us. And later on, people find out this SNP this variant is located in the intron of MTNR1B, which means it doesn't really affect the protein coding of the MTNR1B, but probably affects its regulation of the MTNR1B expression. So indeed, so later some study find out this risk allele actually creates a new rod, which is a transcriptional factor binding site that will increase the MTNR1B expression. So it's a gain of function mutation. When people kind of just measure the mRNA level in the human islets, collected from either non-carriers, heterozygous carriers, and homozygous carriers. You can see there's a dose-dependent increase in MTNR1B expression level in the human islets, further kind of show that this is a gain of function mutation. And also, some other study also show that it's actually the causal SNPs for increased risk of type 2 diabetes. Yeah, so further kind of establish, like this is a very important variant. But one kind of caveat for all this GY study is that it cannot really determine, because GY study, when they measure all the glycemic outcome, is usually like after overnight fasting, during the day, at a time that our endogenous melatonin level is really low, so nearly absent. And considering MTNR1B is a receptor, so we really don't know. So what is its effect on glucose control when the ligand melatonin that is present? So next, I'm gonna just showing you some old studies. One old study is showing like what exactly people have done, just looking at how melatonin affects glucose metabolism. So this is an in vitro study. People used isolated rodent pancreatic islets. So this is a if we look at the control here, which is the white dots. So when you kind of increase the glucose level, so here indicating low glucose level in the media and the high glucose level in the media, so you see an immediate increase in the insulin secretion if under control situation. But however, if you have like 100 nanomolar melatonin also in the media, so this glucose stimulated insulin secretion is almost abolished. So indicating that melatonin can inhibit insulin secretion from this perfused rat pancreatic islets. And then there's also other kind of in vitro studies. So here they trying to mimic the gain of function mutant in the rat beta cell line. So by overexpress MTNR1B in the beta cell line, because it's a gain of function mutation. So when you as here you see, so here is low glucose level exposure, and then we have high glucose exposure here. So if you just giving them like high glucose exposure, like both the control and it doesn't, the insulin release in response to high glucose is not really dramatically, it's not really affected by MTNR1B expression. But if you give them melatonin at the same time, you will see that both the control, because control also have some remaining MTNR1B receptors there, both the control and MTNR1B overexpressing beta cells, they have significantly reduced insulin secretion. And what is more kind of interesting is this above inhibition is more extensive in the MTNR1B overexpressing beta cells than the control cells. So kind of showing that this gain of function will further kind of exaggerate the melatonin-mediated inhibition of insulin secretion. So these are all the in vitro data, and also in rodent tissue. So what is it? What is the effects of melatonin or the MTNR1B genotype in human or in the in vivo situation? So one of the study looking at the melatonin effect is done again something 20 years ago in 22 postmenopausal women, of whom 14 were receiving hormonal replacement therapy. So in this experiment, they have some of them, 13 of them, 45 minutes after giving them either 1 milligram of melatonin or placebo, goes through an oral glucose tolerance test, and the other going to the IVGTT, so intravenous glucose tolerance test. So here are the results of the oral glucose tolerance test. So just showing you that black dots here indicating the melatonin, so you can see melatonin impairs glucose tolerance, while the insulin level didn't really change much. But it could be indicating there's both. It's one is because the insulin level is not changing dramatically, there is still an increase in the glucose level, so indicating there might be some insulin, decreased insulin sensitivity. But on the other hand, because the insulin was not able to increase enough, also indicating the beta cell compensation means beta cell secreting more insulin to in response to the glucose, this function was also impaired. And here they also have the results from IVGTT, similarly, and using some modeling, minimal mod, they kind of conclude that the morning melatonin administration, after overnight fast, reduce glucose tolerance and insulin sensitivity. And then, let's kind of getting the genotype into the picture. So here, it's similarly, we have a oral glucose tolerance test done like 15 minutes after a 5 millimolar melatonin or placebo was given in 17 healthy young women. And also like in this study, they have done this, they have did this OGTT both in the morning and in the evening. So here is a kind of graph showing, so on the top is the carriers of the risk allele, so the heterozygous carrier, and then we have the non-carriers in the bottom. And this is glucose profile after the OGT. I mean, you can clearly see, so it's like the morning they have increased, but there are more pronounced increase in glucose level under the same OGTT in the evening. This is all placebo condition. So this is well known just because we know the glucose tolerance actually vary across the day, while the glucose tolerance is usually getting worse in the evening. So now, what if we, giving them melatonin here? So as you can see here, so in the risk carriers, there is a significant increase in the glucose profile, but not so in the non-carriers. And specifically, so this increase in glucose was like 6 times as large that in the in the carriers as compared to the non-carriers. And so really showing that melatonin in this population, that melatonin impairs glucose tolerance only in the carriers, but it's actually the non-carriers are relatively safe from the melatonin. And also we have the insulin data here. So it's just kind of to show that despite the increase of the glucose level here, so the insulin level is, I mean, the insulin secretion is not that much change, indicating in the morning in the carriers there's probably some pronounced insulin resistance. And also, the beta cell function is, because it's not able to increase further. While the evening probably also both, but seems the defects in the beta cell function is less so because there's some compensatory increase, but just not enough. So here you may ask, okay, so I'm not really taking melatonin on a regular cases, like why should I care about this study? So if you remember, like melatonin is not only kind of elevated when you're taking melatonin. Melatonin will naturally arise, during the nighttime. So this kind of introduced the idea. Okay, what about late meal timing? When you're eating your meal relatively late and concur with your like prevailing increased nocturnal melatonin level. So here is another study showing that how the genotypes and plays a role on glucose control when you simulate early eating or late eating condition. So here they have 800 participants in Spain, and they go through a randomized crossover design. So they either get OGTT simulating early eating situation, which is giving OGTT 4 hours parallel to habitual bedtime, or 1 hour parallel to habitual bedtime to mimicking the late eating condition. So here is a just rough demographic of this population. You don't have to look into details, just to show you there's no significant difference in demographic across all the genotypes. One thing I wanted to point out, so they did measure the melatonin level in the early eating condition and the late eating condition. As you can see, so in the late eating condition, the melatonin level, the endogenous melatonin level is approximately 3 times higher than the early eating condition. So which is, what they're actually aiming for. Yeah. So, and here is the results. So, and here is the non-carrier CC, non-risk carrier, and here is the heterozygous risk carriers, and here is a homozygous risk allele carriers. And you can clearly see there is a dose-dependent impairment on glucose tolerance. As you can see, the glucose AUC is increased as you carry more copies of the G alleles, and also the reduction in the insulin in the insulin secretion is also kind of like have almost dose dependent decrease. So I impair this insulin secretion. Okay, so here I kind of give a rough overview of all the information, or like not all, like some of the information on how the melatonin signaling is actually bad, bad for glucose tolerance. Then next, I'm going to review some, paradoxical information on how some studies showing the melatonin signaling is actually good for the glucose control. So first, again, we start with the GY study. So before I show that the gain of function variance increase the risk of type 2 diabetes, but there is also study showing that there are some rare MTR1 loss of function, mostly happens in the exon. So that will affect the MTR1B protein coding. So here, if so here is some variants kind of completely abolish melatonin binding, so complete loss of function. So they're associated with type 2 diabetic risks increase, and then the even partially loss of function variants also shows a trend towards association with type 2 diabetic risks. And then here is like a study, like an in vitro study where they do prolonged activation of melatonin signaling in isolated human islets. So in the first study, they showed that like in non-diabetic islets, they either cultivate them into like low glucose level or high glucose level, mimicking hypoglycemia for like 3 days. And in the last 12 hours, they give them either placebo or incubate them with melatonin. So normally, and then they wash out all the media and did a kind of glucose stimulated insulin secretion test here. So for this column, where you can see is that so when the human islets was incubated with low glucose level, you see a pretty clear like glucose stimulated insulin secretion effect, but that effect was gone when the islets was pre-incubated with high glucose level. But then if you pre-incubated them with melatonin, you see this, this glucose-stimulated insulin secretion was restored. And then they also did it in the type 2 diabetic human islets, showing that, just normally, the type 2 diabetic islets, they don't really show a pronounced glucose stimulated insulin secretion, but that was restored after pre-incubating them with melatonin. So indicating that, so showing that activation of melatonin signaling in human islets actually can restore the insulin secretion ability in human islets. Then there is kind of looking at the physiological level of the nocturnal melatonin secretion and its association with type 2 diabetes. So here is the case control study. So the participants are from the famous nurse health study cohort, who provided their first morning urine sample in 2000s. So the first morning urine sample, they will contain all the nocturnal melatonin metabolites. So it's kind of a measurement for nocturnal melatonin secretion level. So what they found is that so as the nocturnal the melatonin secretion goes down, you have an increased odds ratio for type 2 diabetes. And then next, another line of research is more from the chronic treatment of nighttime melatonin administration type studies. So first one is a 5 months open label single arm trial. So where they have the participant taking melatonin before bedtime. And they saw after 5 months, they saw a decrease in the HbA1c. And then there is another 3-month study, but the results is a little bit more kind of unclear, because they have, even though they show decreased glucose tolerance, but increased insulin sensitivity, particularly in Jingyi carriers. And then there is another 3 months randomized placebo-controlled trial. They show they show a decrease in insulin sensitivity. One caveat for the last 2 trials is because they both reported when they measure the when they carry out the morning glucose test after the treatment, they also detect an elevated melatonin level, which could be a kind of a leftover effect from their melatonin pill that they were taken the night before. So I would say these 2 trials, they actually showing a combination of chronic treatment effect, but also acute melatonin effect. While the HbA1c, because it's a chronic measurement of glycemia over 3 months, so it's probably like less prone to this, mixed effect of chronic and acute. Okay, so now let's just have a summary of all the, the pro and cons type of evidence. So we have GY study showing both rare and common and like loss of function and gain of function MTNR1B mutations impairs glucose tolerance, increased type 2 diabetes risks. And we have in vitro studies, showing, prolonged melatonin treatment enhance post-exposure glucose stimulated insulin secretion in human islets. But we also have, if given melatonin or have MTNR1B overexpression, inhibits insulin secretion in rodent beta cell line. And we have evidence from the physiological melatonin level. On the one side, we have like low nighttime melatonin level is associated with risk of type 2 diabetes, showing that, melatonin is probably good for glucose control. But then we also have late dinner timing when the endogenous melatonin are high, it impairs glucose tolerance and especially strong in common risk allele carriers. And last, we have pharmacological melatonin level. We have chronic oral nighttime melatonin administration, improved HbA1c, but acute oral melatonin administration impairs glucose tolerance. So all this paradox, kind of like evidence has been confused the field for a while, but now you list it this way, some of you guys may already see where I'm going to. So here I'm gonna showing like one of our central hypotheses that can kind of reconcile all the paradoxical evidence here. Because one thing you can see that for except the GY study, for all the in vitro physiological melatonin and the pharmacological melatonin, the elevated melatonin level that shows improved glucose tolerance test is usually happened when the glycemic challenge is not happening at the same time. So it's either nighttime melatonin, usually when people are fasted and not really eating, but when the evidence showing the melatonin impairs glucose tolerance, that's always the glucose challenge or glucose test is happening at the same time when the melatonin levels are high. So here comes our central hypothesis so here, like, for the low melatonin condition is usually during the circadian day as endogenous, or your nighttime melatonin was suppressed by light exposure, or we have high melatonin situation, which is usually when there is circadian night, or you have ingested exogenous melatonin. So when at this time you are fasted, you are not going through glycemic challenge. You actually, because you have because your insulin secretion was inhibited by the high melatonin level, you actually allow your beta cell to rest at the same time. While if you have low melatonin level, your beta cell, cannot get really, this good rest. So that's why it could be, bad for you. But however, when you are going through a postprandial challenge, because acutely, so the high melatonin level will reduce your beta cell function, reduce your insulin sensitivity. So that's why it's bad. But if you don't have melatonin here, so you maintain your normal function of beta cell function and insulin sensitivity. So that was good. That's kind of like our series to kind of reconcile all the paradoxical evidence out there. But later on, like the trial that I'm going to show you, we're mostly focusing on the high melatonin level situation. So we were primarily looking at how melatonin, whether the high melatonin level will affect beta cell function, insulin sensitivity, using more sophisticated glucose test, and also we'll also look at secondary M, whether after prolonged melatonin exposure, whether the beta cell insulin secretion will be restored. So okay, so now let's go to this trial. So the research question we have here is, what is the underlying mechanism of the acute effect of melatonin and MTNR1B risk common variants on the glucose control? So some major limitation of the parallel study we're trying to address here is a lot of previous, like the small trial, mechanistic trial, they only included one biological sex. And they lack sophisticated modeling to teasing out the different key components of glucose control. So didn't allow us to really know the in-depth of the mechanism. And also, a lot of those studies, the lack of control of the parallel diet, sleep-wake schedule, and physical activity level. All of those we know will affect our glucose metabolism. And also, like, because a lot of those studies before, they're like also small, like small in-depth trials, they usually are not powered to really test the difference between MTR and genotype. So, and here is our protocol. So we have the participants like, keep a regular their habitual their self-selected 8-hour sleep habitual sleep-wake cycle for the 2 weeks parallel they come into the lab. And 3 days before they come into lab, we'll also provide them with standard test meal and also tell them to refrain from exercise. So we have some really good control of sleep-wake cycle and parallel diet and also parallel physical activity level. Then they come into the lab where we control everything and monitor everything. They live in the lab for 5 days. So on the day 2, after 7 hours since they wake up, we give them either a 5 milligram melatonin or 5 milligram placebo, in a double-blinded randomized crossover matter. And then an hour later, we have them go through the frequent sampled intravenous glucose tolerance test where we derive our primary outcome. And then the next day after they take a full night's sleep, so we have another mixed meal test next morning to see whether the insulin secretion will be kind of restored or enhanced in one of those situations. And then on day 4, day 5 is the same protocol, but it's just like whether they if they taking the different medication. Okay, and here is our participant population. So the inclusion criteria is, we have a 21 to 55 years old, and the BMI is like normal to overweight. And we include people with based on HbA1c, whether they're pre-diabetes or normal glycemia, but exclude the type 2 diabetic patient. We only included a white non-Hispanic patient because when the study was designed quite a while ago, we only have GWAS data out there for for people with European ancestry. So because we don't know the genotype effects on other ethnicity yet. So we only that's one of the limitations. We only have a white non-Hispanic participants in this study. And we kind of don't allow them all overall very healthy. So no medication use was allowed except contraceptive. So we have 11 non-carriers and 10 carriers, including both heterozygous and homozygous carriers. And there's no difference in the basic demographic characteristics. And so first, let's look at exposure. So we give them, the melatonin or placebo, melatonin here in red. This is all the study population. As you can see here, so, as anticipated, after having 5 milligram of melatonin, the melatonin shoots up to like over 1,000 picogram. It's really, really high. But then it gradually calms down. Like before they go into bed, they actually come down to the physiological level, and it doesn't really, doesn't really affect their normally endogenous secreted melatonin level in the evening at nighttime. And this is true for both carrier and non-carrier, just showing that the exposure which we given melatonin and placebo is the same among carrier and non-carriers. And then here is our frequent sampled intravenous glucose tolerance outcome. So here is where we give the melatonin or placebo. And then at time 0, we give them like, dextrose. So it's a glucose solution infused into their vein. And you see this sharp increase in glucose. And also in response to that, you see this endogenous insulin also kind of have a zoomed in insert here. So this endogenous insulin secretion and this sharp peak C-peptide, which is a byproduct of insulin, but it's more stable. So you also see the C-peptide increase. And then at time 20, we also inject them with proportional to their body weight insulin level, which is like a very high insulin dose will shut down their endogenous insulin production. And also, like, you know, the because it's a standardized insulin dose, by kind of modeling the glucose disappearance rate here, you can get a sense of the insulin sensitivity. So here is all the participants. And in the carrier, you know, just by looking at the graph here, you can see the difference after the melatonin treatment. So under melatonin treatment, the glucose clearance is actually, like, you see this elevated glucose level. And you also see this kind of reduced insulin secretion, insulin endogenous secretion here, while not so in the non-carriers. So what does this mean? So okay, so next, the statistics was wrong on like more concrete stats. So we do, as we observed in the graph, we see that the glucose incremental area on the curve was significantly increased in the carriers, but not so in the non-carriers. And also there is a interaction, genotype difference. And similar to our observed, the insulin incremental AUC, 0 to 20 minutes, which is really the endogenous secretion, that the carrier was reduced, but not so in the non-carriers, similar with the CPAP. And for the model-derived parameters, so we did not see, any difference or genotype-based difference in disposition index, insulin sensitivity, but we do see that the first phase beta cell responsive index was significantly reduced in carriers. Actually, all the individual here are reduced, like no exception, while not so in the non-carriers. This is very interesting. So this index is actually very clinical relevant, because there are studies have shown that the first phase beta cell responsive index of first phase insulin secretion is an independent predictor for type 2 diabetes. Okay, so this is the primary outcome from the FSI-GT, and then next we can look at the mixed meal test in the next morning. So here is a rough overview of all the glucose, insulin, and the CPAP response during this mixed meal test. So we did not see the difference in the glucose AUC or insulin AUC or CPAP AUC, but we do see for the early phase insulin response, there is a trend for the carriers to have an increased early phase insulin response under melatonin, but not so in the non-carriers. But it's a trend. So one caveat I want to point out is, if you remember the melatonin exposure, the nocturnal melatonin exposure, because we anticipate the original anticipated exogenous melatonin intake will elevate the melatonin level kind of across the night, but that's not something we really observed. The melatonin actually kind of like quickly got cleared, and we actually don't have, so the melatonin treat group and the placebo group actually have the same nocturnal melatonin level there. So that may be part of the reason, that the effect was not strongly showing here. That's just one of the caveats when we discuss the results. And so last, the conclusion. So based on all these results, we conclude that exogenous melatonin administration significantly impair glucose tolerance and beta cell function in MTNR1B risk carriers, but not in the non-carriers. The first phase insulin secretion plays an important role in mediating the effect of melatonin on glucose and its interaction with MTNR1B genotype. And also we have some suggestive evidence, but of course needs further investigation, that whether prolonged exposure of melatonin exposure will improve early phase insulin secretion the next morning. So last, some future directions. So for people, like for us to better understand this melatonin signaling in glucose control. So first of all, like the acute effect, what is acute effect of activation of melatonin signaling on glucose stimulated insulin secretion in human pancreatic islets? Because previous all the study I've shown you are all done in rodent, and rodents are usually not like nocturnal while human are diurnal. You're just wondering like whether that will make a difference here. And second, what is really the chronic effect? Like eliminating the acute effect of melatonin nutrition during overnight fast on beta cell function and insulin sensitivity in carrier and non-carrier. I think there still needs a more better designed kind of trial to really address this question. And third, other effects of melatonin MTNR1B genotype on glucose control are melatonin dose dependent. We have shown a lot of studies showing that it's a risk allele dose dependent, but is there a difference between like physiological level of melatonin or pharmacological level of melatonin? And last, we know the endogenous melatonin secretion can be suppressed by light. We wanted to know whether light suppression of this melatonin secretion can mitigate the melatonin-mediated adverse effects on glucose control. But this is kind of very relevant for people who are like shift workers or who are jet lags, because if we know the light can mitigate that effect, it could be, a intervention for people who can just not avoid to eating at a later time. Okay, last but not least, I would like to thank my team. I like to especially thank Dr. Frank Shears, my mentor, and also Marta Garolet and Dr. Richard Saxena, who are the three really started this project, and I joined shortly after. And our mathematical modeling, Darko Stefanowski from UPenn, and our endocrinologist on the team, Dr. Adler and Thomas Manger-Paulson, and all the statisticians and RAs and participants in this study. Thank you.
Wow, thank you. I know we're at the top of the hour, but if any of you can stay around a little bit longer, we'd love to have a little bit of a chance for questions. Anyone have a question for Dr. Qian? A few people had to leave because of other meetings.
Yeah.
So I have a question just clinically using melatonin in many patients, especially post-COVID, because COVID does have some major impacts on sleep disruption. The current thinking from sleep psychologists as well as sleep doctors is to, and Eric can give me more insight into this since you know this area better than I do, but is using low dose melatonin, like 1 milligram or even lower, given 2 hours before bedtime to really enhance the initiation of sleep. And that's kind of the way I've been clinically using it, at least for the past 2 to 3 years. And I have boatloads of patients who are taking, including family members who are taking like 1 milligram of melatonin, and they really find it, quite helpful. And this is beyond one person. I'm talking about across 20, 30 people who I know taking that it is quite helpful to regulate sleep. And so are there any observational data looking at overall glucose tolerance or even just hemoglobin A1C levels across people using melatonin chronically in low dose forms?
I don't think particularly low dose form, but I think there is one study, I forgot who is the first author. They did look at melatonin usage on I think glucose control. Yeah, so but low dose is really a good question. I don't think anybody has looked at it. And also just such data probably need specific study design to collect, because people usually just taking melatonin and don't really let their doctor know. Yeah.
Other questions?
I had a question
Really
about
Sujata?
Hi, yeah. Thank you so much, Dr. Qian, for the fantastic talk. I had a question. Do you know of any pediatric trials like comparing if children who are taking melatonin, they have like increased chances of insulin resistance, or because it's now become very common in pediatrics as well?
I'm not aware of any such studies in adolescents or children's population, but that's a really good point. I think part of it is just because that such study is a bit hard to do. You know, you need like special trained people, and you know, the RB gonna be a hustle. But you know, I would really interesting to know that as well. And also another thing we know is like children, you know, they have a different, especially adolescent, they have a different chronotype. They tend to be more late chronotype, as compared to, so that makes you think, okay, you know, because normally we're worried about late eating time. So in the adolescents population, you almost need to wondering, are they like eating too early will be bad for them as well, because they may have the melatonin not fully kind of reduced to baseline level in the early morning. But I think that will be a very interesting like question for really good design study to answer. Yeah.
Mm-hmm. Thank you.
Yeah.
Was there a question from the room with people in person?
No, it was a beautiful presentation. We learned so much, so thorough and scholarly, and your own research plus the field, complex field. Thank you.
Yeah. Looks like there's a lot more to learn about timing of meals, timing of physical activity, timing of melatonin.
Yeah.
And it just makes, I mean, some of the data you showed kind of reinforces how complex this is when we think about genotype and environmental interactions. Like, we are totally missing the boat when we just look at, you know, things in one context, whether it's a fasting context or a non-fasting context, and then we don't involve the genotypes, and that's leads to so much heterogeneity in our findings. And so this is kind of the brave new world, is, you know, getting multiple different you know, inputs on what we're doing. Yeah.
So I just, from a, you know, as a trained chronobiologist, we always feel like you really need to consider timing, like in your research design or in your studies, because when you do the test, sometimes like initially it just matters, like for glucose tolerance, if you do it in the morning versus do it in the evening, in the afternoon, you may have a misdiagnosed type 2 diabetes. But the same for the research, like for the rodent study, for example, before, a lot of the cognitive tests are done during the day, where is when the rodents need to sleep. So
they're
yeah,
tired,
so yeah,
tired rodents.
yeah. So I feel like it's always good to keep, you know, like this one additional dimension in mind, is like the timing. Yeah. And also, you know, it can play, you know, right now is another like really booming area is we talk about chronotherapy. Of course, this is still need a lot of evidence to kind of to prove that's, you know, to show the evidence is really there. But it's a very interesting area showing that maybe, you know, if you eat at different time, exercise at different time, or maybe even you're giving the medication at different time, you may show a different efficacy. It's really kind of getting into the area of like, you know, personalized or more targeted precision medicine. Yeah.
Great. Well, thank you so much, Jingyi. I learned a lot, and I look forward to learning more with your future research.
Yeah, thank you. Thank you
Okay.
all.
Thanks everybody for joining.
Thank you so much.
Thank you.
Bye.